So welcome back to the Veterinary Technician online review course. We are moving on to 2.3 of Anatomy and Physiology, which covers the cardiovascular and the respiratory systems. Lecture number 1, we are going to start with the cardiovascular system. So the cardiovascular system is responsible for the movement of blood and everything it carries throughout the whole entire animal's body. So this includes the heart, the blood vessels, and the blood itself. It carries electrolytes, waste material, nutrients, hormones, antibodies, and drugs to every living cell within that animal's body. So obviously we're going to start with the heart. The location of the heart is in the middle of the thoracic cavity, and it lies within an area called the mediastinum. And this is the space that lies between both lungs, both side, the right and left side of the lungs. It contains the heart, the blood vessels. Thoracic portion of the trachea actually goes through the mediastinum. The esophagus passes through this, and the thymus in young animals, because if you guys can remember, the thymus kind of shrinks and disappears in older animals. And also lymph nodes and nerves are found within the mediastinum. The covering of the heart, so the heart itself is covered by a membrane, and it's contained in a fibrous sac. Okay, that's what that membrane is. It's a fibrous sac. And this is called the pericardium. And the pericardium is divided into two different parts. So we have the pericardial sac and the serous pericardium. So the pericardial sac is loose so that when the heart beats, it can move with it. So it's loose, but it doesn't stretch. It's not like elastic. So when we have an enlarged heart, it can put quite a bit of strain on this pericardial sac because it's not elastic. It doesn't stretch with the heart when it becomes enlarged, but it is loose so that the heart can beat within it. And then we have the serous pericardium, and again, the subcategory to this subcategory. The serous pericardium consists of two different membranes. We have the parietal layer, which is smooth, moist, lines the pericardial sac. So that sac that surrounds it, that heart, that's that loose sac, the parietal layer or parietal layer lies touching that. And then we have our visceral layer, which is the membrane that lies directly on the surface of the heart. So it's kind of like one touches one surface and the visceral touches the other layer. And if you can remember, the word viscera just means organs. So the visceral layer touches the viscera, which is the actual organ. And the serous pericardium, so those two membrane layers, the parietal layer and the visceral layer, are actually filled with pericardial fluid that helps lubricate all these layers while the heart beats, so no friction is created with that beat. So here's an amazing picture. If you look over here, this is a beautiful picture of a heart, and you can see the scissors are lifting up this pericardial sac. And so this sac lies right around this heart, covering it. And this picture here will show you the two different layers, the visceral layer touching the heart, and then the serous layer that's touching the pericardial sac. So this here is giving us a closer look of these two layers of the serous pericardium. You can see the parietal layer is right here and the visceral layer is right here, okay? And this is our heart, the myocardium. Myo means muscle, cardium means heart. So this is the heart here. So the visceral membrane hugs the heart and the parietal layer hugs the pericardium. So the wall of the heart, so the muscle of this organ itself, is made up of three different layers. There's the epicardium, the myocardium, and the endocardium. So the epicardium is the outermost layer of the heart. That shouldn't be hard to remember because epi means on the surface, right? So the outermost layer of the heart. The epicardium is the visceral layer of the serous pericardium. So again, just to confuse you, perhaps the epicardium is the visceral layer of the pericardium, so I suppose that membrane would have two different names. Then after that we have the myocardium, myo meaning muscle, so it's the thickest layer, it's the muscular layer, so it's the actual muscle. It's joined side to side by end-to-end intercalated discs. We talked about these intercalated discs when we were talking about cardiac muscles. It is autorhythmic, which means that it does not fatigue and it never takes a break. The second that the embryo is formed within the uterus in the mother, that is when the heart starts beating, and it does not stop until death. It is autorhythmic. It does not ever get tired, and it never takes a break, or at least it shouldn't. The very last layer of the heart is the endocardium, which lies on the internal surface of the myocardium. It's a thin, flat, simple squamous epithelial, and it lines the heart chambers. Here you can see the layers of the heart. You can see out here, starting with the fibrous pericardium. After that, we have our parietal layer. Okay, so this is the first layer of the serous membrane, moving into this cavity. Remember, I said within these membranes, there's a fluid that helps lubricate, and that's where you'll find this. Now, the pericardial cavity is very small. It's not a huge space, but it's a very small one. Then we have our epicardium, which is actually the visceral layer of the serous membrane. But this is the epicardium. This is the myocardium. So this is the heart muscle itself. And then this very thin line here is the endocardium, and this lines within the inside of the chamber of the heart. Now let's talk about those chambers. So the chambers within the heart, there's 4 different chambers. There's 2 atria. These guys receive blood into the heart, and they sit on top, so they're cranial to the ventricles. And then there's 2 ventricles, which are the lower, more caudal chambers, and they pump blood out of the heart. So this right here is a picture showing you, remember your rights and left whenever you're looking at a diagram. You're always looking like as if the patient is laying on its back facing you. So your right is over on that side and your left is over on that side, which may seem opposite, but just try to remember that whenever you're looking at a diagram, that's how you're visualizing it. So you can see that the 2 atria there, there's one on the right and left side, and then there's 2 ventricles on the right and left side. The deoxygenated blood is usually depicted as blue. So on the right side of the heart, that's where deoxygenated blood enters the heart. And on the left side of this heart, oxygenated blood is typically depicted by a red color. And this is where the oxygenated blood comes in to the heart from the lungs with that yummy oxygenated blood, and it goes out the arteries to feed the whole body with the oxygenated blood. So the atria, there's a left and a right atrium, and they're separated. So what separates these 2 atria is called an interatrial septum. So it is a continuation of the myocardium, so it still is that heart muscle, but the separation between the right and left atrium is called the interatrial septum. The atrium and the ventricle are separated by one-way valves. They receive blood from large veins that carry blood to the heart. Okay, so remember the atria always receives blood from somewhere. When filled with the blood, they contract and send blood through this one-way valve down into the ventricle. From the outside of the heart, the atrium is identified by its auricle, and I'm going to show you a picture of what this is. But they say it's like a blind pouch that comes off the main part of the atrium, and it almost looks like an ear flap. And the word auricle actually means ear, so that's where it gets its name. But I'll show you guys a picture of this. So from the outside of the heart, that's how you can identify the atrium, is by this auricle that you can see on the surface of the heart. The myocardium around the atria is not thick, because really the atrium only has to move blood just down to the ventricles. It doesn't need that much force to push it anywhere. It's just going down to the ventricle, and it needs to move through this one-way valve, so it doesn't need much force. So this right here is showing you the interatrial septum. So this is what's separating the left atrium from the right atrium, is this section right here called the atrial septum. And then we can also see in this picture here the one-way valves. And the one-way valves, literally, the blood can only go this way, and that's it, no other way, thanks to these one-way valves. This right here is showing you the auricle. So on the outside of the heart, so if we were to remove the organ itself, we would be able to identify the atria from this auricle which is right here. So this is the auricle of the right atrium, and it has this ear flap kind of structure to it, hence why it's called auricle, and that lies right over top of the atrium. So the ventricles, the left and right ventricle is separated by an interventricular septum. Remember the other, for the atria, it was the interatrial septum. This is the interventricular septum. And the interventricular septum is actually just a continuation from the interatrial septum. So it goes down, and together they make the atrioventricular septum. So that shouldn't be too hard to remember. A septum is something that separates and divides, and then the atria one is the interatria, inter meaning between, so in between the atria. The interventricular is in between the ventricular septum, okay? And both of them together, like that whole septum from top to bottom, is the atrioventricular septum. So when the ventricles fill with blood from the atria, so the atrium is going to dump its blood through the one-way valve into the ventricle, the myocardium of the ventricle then contracts. So then the blood is going to pass through another one-way valve into arteries. And we have to remember that arteries are going away from the heart and veins are going towards the heart. So if we're talking about the right ventricle, it's going to push that blood out of the ventricle and it's going to go out of an artery, but it's going into the pulmonary artery because that is deoxygenated blood on that right side of that heart, and it needs to go to the lungs so that it can get rid of CO2 and pick up oxygen, and that goes out through the pulmonary artery. Now, the right ventricle has a smaller myocardium, so has a smaller muscle due to it needing minimal force to send blood to the lungs. So remember, the right side of the lung, the right side of the heart, the right ventricle, only needs to pump that blood out the pulmonary artery and to the lungs. That's it. That's the only place it goes. And then it comes right back to the heart. So it doesn't need as much force, whereas the left ventricle, it sends yummy oxygenated blood out the aorta, and it needs to feed our entire body from top to bottom. So it needs an amazing amount of force. So that myocardium on the left ventricle has the most work to do, so it has the thickest wall. Right here you can see the difference in thickness. This is the left ventricle here, and it's huge, right? That myocardium is huge as opposed to the right ventricle, which isn't as big because the right ventricle only pumps it to the lungs. That's it. But the left ventricle has to pump it throughout your whole entire body. So you can see the differences in the muscle thickness. So let's talk about the chambers, the valves of the heart. We've talked about all four chambers, but there's valves in between these, and up to now we've just been calling them one-way valves. And there's four of them, and they all have a name, so we're going to talk about that and what they do. So the one-way valves control blood flow. They close at a specific time to prevent backflow of the blood into the chamber it just came from. So if the right atrium dumps its blood into the right ventricle, this one-way valve will bring the blood from the atrium down to the ventricle and stop it from going backwards. We can't have that happen. If it does, that's a major heart condition, and we can't have that happen. So thanks to these one-way valves, typically in a healthy patient, that's what they do. Blood within the heart needs to flow in one direction only. Two of these valves are located between each atrium and its ventricle, and then two of them are located between each ventricle and its artery. So the first valves that we're going to talk about is the atrioventricular valves, the AV valves. They're located between the atria and the ventricle. There's a right AV valve and there's a left AV valve. Now the right AV valve is actually called the tricuspid valve, and the left AV valve is called the mitral valve. They open when the pressure from the blood in the atrium forces the valve to open and dump into the ventricle. So when the blood gets to the atrium and it fills to a certain point, there's going to be so much pressure, the valve's going to open and dump it into the ventricle. It closes when the pressure is greater in the ventricle than it is in the atrium. So when it dumps it down into the ventricle, all that blood's going to be in the ventricle with very little in the atrium, and then it'll snap shut again, stopping it from backflowing. Does not open backwards because it is attached to the Chordae Tendinae, and I'll show you a picture of the Chordae Tendinae in a second. But these are collagen fiber cords that attach the valves to the heart. So these valves are attached by these like spider web looking cords, and it stops them from opening backwards. The second type of valves are the semilunar valves, and these guys are located between the ventricles and their arteries, so it's always going to be exiting. This is when the blood's going to be exiting the body into arteries. We have the right semilunar valve, and that's actually the pulmonary valve because that blood is going to the pulmonary vessels, hence why it's called the pulmonary valve. And then we have our left semilunar valve, which is called the aortic valve because that blood is going from the left ventricle into the aorta. And this right here will show you that. So initially the blood's going to dump into the right atrium, and once the pressure in this area here in this atrium gets too full and the pressure is high, this tricuspid valve or the right atrioventricular valve will snap open, dumping all the blood into the right ventricle. Once this pressure, all the blood's in here, not up here anymore, the pressure is going to be bigger down here and these will snap shut. And then it's just hanging out in this right ventricle. And then the same thing happens over on this side for these AV valves. This picture here is showing you the Chordae Tendinae. I told you it was like that spider web looking stuff, and this allows or prevents the AV valves from going backwards. And then this picture here is showing you the semilunar valves, well, also the tricuspid and the mitral valve as well, but it's going to dump into the atrium. It's going to dump through this right AV valve into the ventricle, and then the ventricle is going to come up here through the pulmonary valve. This is one of the semilunar valves here, and it goes up in here to the pulmonary system. But on this side of the heart, on the left side of the heart, it will go up this way through this semilunar valve, which is actually called the aortic valve because it leads into the aorta. So we often talk about how the heart supplies our whole body with all this blood and takes all the garbage away from it. But what about the heart itself? How does that get its blood supply? So there's coronary arteries and coronary veins that are responsible for bringing oxygen to the heart tissue itself and moving waste away from the heart tissue. The coronary arteries, they actually branch off of the aorta, and the branches go around the heart and encircle it. Most of its blood supply goes to the left ventricle because that's the one that is going to be utilizing the most energy, and passes through capillaries in the myocardium and enters the coronary veins. So that would then be the deoxygenated blood. And the coronary veins return to the blood circulation. All coronary veins join together near the right atrium and form a channel called the coronary sinus. And that's where it's all going to dump into the right atrium. This right here is showing you the coronary circulation. So the red veins are shown to you. Those are arteries with oxygenated blood, and you can see how those hug the myocardium. And then once they are done with the arteries, they will go through capillaries and make their way to the veins, which contain the deoxygenated blood. And that deoxygenated blood will find its way back to the right atrium to be dumped into the right atrium to be recirculated again. So blood flow through the heart. Now this is literally through the chambers and stuff, not how the heart gets its blood supply, but how it flows through it. So the entire purpose of the heart is to receive deoxygenated blood from the systemic circulation, send it to the lungs for oxygenation via the right side of the heart. They receive the fresh oxygenated blood from the lungs and put it into the systemic circulation via the left side of the heart. And then once it's gone through our whole entire body and supplied our body with oxygen, the deoxygenated blood will find its way back to the heart, and this cycle will continue all over again. Amazingly enough, when you think about it, your heart as an adult human typically does this 80 times in 1 minute. So it's quite impressive. So let's talk about the right side of the heart. The deoxygenated blood from your body is always going to make its way to the right side of the heart. The veins collect deoxygenated blood from tissue, and the vena cava is the big vein that's going to carry this deoxygenated blood into the right atrium. Once it dumps into the right atrium, and it fills up and there's so much pressure in it, the blood is going to pass through the right atrioventricular valve, and it's going to dump into the right ventricle of the heart. During systole, so during that contraction, that right ventricle is going to contract and the tricuspid valve closes, And then the blood is going to be injected through the right ventricle through the pulmonary valve. Remember that semilunar valve? So that right AV valve will snap shut, but the semilunar valve will open up and allowing that ventricle to pump its blood into the pulmonary arteries. So from the pulmonary arteries, the blood passes through the branching vessels to the pulmonary capillaries of the alveoli, and that's where the oxygen exchange takes place. And that's where deoxygenated blood will then become oxygenated. So now that our blood is oxygenated, the blood is going to flow through the pulmonary capillary network. Vessels begin to merge together and increase in diameter, eventually becoming a pulmonary vein. Remember, veins go towards the heart. So this pulmonary vein has oxygenated blood going towards the heart, and now we're working with the left side of the vein, or left side of the heart. So the pulmonary vein brings blood into the left atrium. Blood flows from the left atrium. Once the pressure is built so high, it'll flow through the left AV valve into the left ventricle. During systole, this AV valve will snap shut and the ventricle contracts and the blood will go, the blood enters the coronary arteries and the aorta through the aortic valve. So it'll go through that semilunar valve and make its way to the aorta. From the aorta, the blood travels through the arterial branches into capillaries, and oxygen and nutrients exchange will happen with the tissue within the body that it's leading to. And then eventually, once that oxygen's all gone and it's fed all the tissues, it turns into deoxygenated blood again and makes its way to veins, and it'll travel back to the heart to do it all over again. This here is showing you how the blood is traveling through the heart. This right here is, the superior vena cava, and this is the inferior vena cava, but both of these vena cavas are dumping into this right atrium. Once this pressure gets so high, it'll go through this valve. This is the right AV valve, the right atrioventricular valve, and it'll dump into the right ventricle. During systole, this myocardium right here is going to contract, pushing the blood out this semilunar valve, which is the pulmonary valve, and it'll come out here going this way into the left side of the lungs or this way into the right side of the lungs. Once it's in the lungs, it's going to make its way to the capillaries that are hugging the alveoli, and it's going to give CO2, which is garbage, and take O2, which is what we want. And that's how that blood becomes oxygenated. Once that blood is oxygenated again, it's going to come in from the lungs. So over here, it'll come in through these pulmonary veins, and over here you'll see the pulmonary veins as well coming in, but it's all leading into this left atrium, and we have yummy oxygenated blood that's ready to feed our entire body. Once this pressure gets so high, this left AV valve will open up and dump it into the left ventricle, and this is where the biggest part of the myocardium is, because we have to, this side of the heart has to pump it not just to the lungs, it has to go through our whole entire body. So systole happens, blood will push through this aortic valve, the semilunar valve up here, and it'll dump out of this largest artery in the body, which is the aorta. And these are the coronary vessels, it'll feed different areas in our body. And the aorta will go down this way, down, and feed the rest of our body with the oxygenated blood. So then that oxygenated blood will go to all of our tissues within our body. It will give oxygen to the tissue and take CO2 away. And now it's deoxygenated blood. So it has low O2 and high CO2, and that deoxygenated blood will make its way back to the right side of the heart this way, into the superior and inferior vena cava, to dump back into this atrium and start all over again. The conduction system. So this is the electricity of the heart. This is what makes the electrical activity in the heart that makes it pump. Areas of the heart have developed to initiate an impulse that moves through the myocardium. So it stimulates muscle cells in the wall of the atria to contract, and then moves through the ventricular walls to cause them to contract. One cycle of atrial and ventricular contraction and relaxation is a cardiac cycle, and this produces one beat. And so that's one contraction, one cycle of the atria and the ventricular contraction, and then the relaxation afterwards. That is one cardiac cycle, one heartbeat. So a cardiac cycle, these are terms that are very important. Systole is the heart muscle contracts. Blood is ejected from the atria to the ventricle and from the ventricle to the arteries. And then we have diastole, which is where the heart relaxes and refills with blood to be ejected during the next systolic contraction. So systole and diastole. So this is important during blood pressure. You'll have a systolic pressure and a diastolic pressure, and that's what we're talking about there. Systolic pressure is the pressure of the blood being pumped and pushed out of the heart during contraction, and diastole is the relaxation. This right here is showing you a heart during diastole where it's filling with blood, and then you can see during systole where it contracts. You can see the myocardium squeezing those ventricle to pump it out into the pulmonary artery or the aorta. Structures of the conduction system are these four main parts. So we have the sinoatrial node, the atrioventricular node, the bundle of His, and the Purkinje fibers. So this is exactly where the electricity flows through. The 1, 2, 3, 4, it flows through these four areas of the heart. So in this image here, you can see the sinoatrial node, which is up here in the right atrium. And the electricity is going to shoot down here to the atrioventricular node. After the electricity goes through there, it's going to go down here, which is the bundle of His. So it goes right down the interventricular septum, and that's the bundle of His. After that, it'll creep its way up and around the ventricles, which is called the Purkinje fibers, and that causes one heart contraction when the electricity flows that way. So the impulse starts at the sinoatrial node, like I said. It's located within the right atrium, also known as the pacemaker. So when you hear of someone getting a pacemaker, they're getting basically an artificial SA node, which is going to initiate that electricity to cause that one heartbeat. The impulse travels from one muscle cell to the next, and we talked about muscle cells and how they work and how they kind of move in a wave-like fashion, right? So initially causes both atria to contract, and the blood pushes through the AV valve into the ventricles. Atria contracts. This is also called atrial depolarization. So when I talk about a muscle depolarizing, when we're talking about the cardiac conduction system, I'm talking about the heart contracting. So atrial depolarization is when the atria contract and push the blood down into the ventricles. The impulse also travels quickly down the muscle fibers to the atrioventricular node, which is still in the atrium. Electrical impulse then spreads through the bundle of His, so down the interventricular septum there, travels down the interventricular septum to the bottom of the ventricles, where it then hugs up around those ventricles up the Purkinje fibers. And the ventricles contract. This is also called ventricular depolarization. Remember, depolarization just means contraction. And then after that, repolarization happens. For a quick millisecond, a repolarization happens where the heart just relaxes. And again, this is a picture showing you the conduction system. So you can see the SA node up here, shooting down to the AV node, shooting down the bundle of His and up into the Purkinje fiber, causing one heartbeat. Now, heart sounds, we often refer to a heart sound or a heartbeat as lub-dub, lub-dub. So lub would be S1, and it's the closer, it's actually the closing of the right and left atrioventricular valve. So when we hear lub-dub, that lub is your AV valves snapping shut. And this happens at the beginning of ventricular systole. So when the ventricles contract, those AV valves will snap shut. The mitral valve is the loudest on the left side of the chest, and the tricuspid valve is best heard on the right side. So the second sound that we hear is dub, so lub-dub. We know that lub is the snapping shut of our AV valves, and dub, which is S2, the second sound, is actually the closure of the semilunar valves at the beginning of ventricular diastole. So once the ventricle has contracted and pushed all that blood out into the arteries, those two semilunar valves will then snap shut, and that's the dub. So lub-dub, lub-dub are Literally, it's the valves that you're hearing snapping shut. In large animals, you can hear additional heart sounds. You'll have a third and a fourth sound where you can actually hear in large animals the rapid ventricular filling of blood, and that's S3. S4 being the contraction of the atria that you can actually hear, but that's only in large animals. So cardiac output. Cardiac output is basically how much blood is being pumped out of your heart in 1 minute. Like volume-wise, we're talking about a volume. So it depends on your stroke volume, which is the amount of blood ejected with each cardiac contraction. So every time my ventricles contract, how much blood is it squirting out? That's my stroke volume. And it also depends on my heart rate, so how fast my heart is beating. So a normal cardiac output in human females is 4.9 liters per minute, which is amazing. When you think of a 4-liter jug of milk, that's like the biggest jug of milk that you can buy. Human females pump out that plus 0.9 liters in 1 minute. That's how much blood my heart is pumping out in 1 minute. That's amazing. In human males, they require even more. They have a higher cardiac output, and it's 5.6. So if you think about, it's basically one of those huge 4-liter jugs of milk as well as a 2-liter container of milk. Both of those together is what a human male, pumps out of his heart in 1 minute. That is amazing. And dogs, they don't come too far behind human females. They produce about 4.4 liters per minute. So in a 8-kilogram dog, which is, let's say, probably around a 20-pound dog, they can actually produce. And again, with the dog, it's a little bit difficult. There's not one standard size, right? Dogs vary from 2 pounds all the way up to 200 pounds or more. So depending on the size, obviously. And an 8-kilogram dog can produce almost 2 liters a minute, which is quite impressive. So this here shows you the calculation of cardiac output is the stroke volume. So again, it's the amount of blood in one pump of my ventricle that's getting squirted out, and my heart rate. So vigorous exercise results in an increased contractility, increased stroke volume, and increased heart rate. So you can imagine my cardiac output's going to go up as I exercise. Stroke volume is how much blood, for example, the volume is being projected with each beat. And the heart rate is the speed, the rate of cardiac contraction. So we already mentioned that before. So obviously vigorous exercise is going to increase our cardiac output. It's also influenced by the autonomic nervous system. So fight or flight response, the sympathetic nervous system releases epinephrine. Okay, so it's like adrenaline. And the stroke volume and the heart rate increases during fight or flight. So I keep using the reference of a dinosaur busting into my room right now. My sympathetic nervous system would kick in and I would go in fight or flight response. And thanks to the epinephrine that's being produced by my adrenal glands, putting me into fight or flight mode, my cardiac output is automatically going to go up. My stroke volume is going to increase and my heart rate's going to increase. My stroke volume is going to increase because I'm going to need more blood to get to my legs for me to run, and my energy requirements are going to increase, and my heart rate is going to get faster to pump this blood faster. General anesthesia can also affect cardiac output where the parasympathetic nervous system. Now keep in mind with this fight or flight sympathetic nervous system, the parasympathetic nervous system is what returns everything back to homeostasis, brings everything back to normal. So during general anesthetic, the parasympathetic nervous system releases acetylcholine and the stroke volume and the heart rate actually decreases. And that's why anesthetic monitoring is so important, because this parasympathetic nervous system can decrease our cardiac output, therefore causing bad perfusion, right? So if I don't have the right amount of blood being pumped out of my body at the right rate, so if I don't have the proper cardiac output, how am I sure that all of my tissues are getting the proper amount of oxygen that it needs? So we have to be really careful with this during anesthesia. Vasculature, we've already talked about this. Blood vessels make a continuous loop to and from the heart. We talked about arteries, which usually appear red because it's oxygenated, and arteries are leaving the heart. And then we have veins, which usually appear blue because they have deoxygenated blood, and veins go towards the heart. Now, typically they appear red and blue, but you have to understand that some arteries, even though they're leaving the heart, do contain deoxygenated blood, so it may still be depicted as blue. For example, the pulmonary artery, it's called an artery because it's leaving the heart, but it still contains deoxygenated blood because it has yet to go to the lungs to do that gas exchange. And the same thing with the pulmonary veins that are coming back into the left side of the heart with that yummy oxygenated blood. It's going to be depicted as red, even though it is a vein, because it's going towards the heart. And then we have our capillaries, which are the little teeny tiny vessels that kind of are the middleman between the arteries and the veins. This right here, this picture is showing you the differences between all three veins. Arteries carry blood away from the heart, and the aorta is the largest artery in the body. Other smaller arteries branch off of the aorta, and these other smaller arteries are actually called arterioles, and these are the smallest of the branches of the arteries, and these are the ones that will connect with the capillaries. So if you're looking at this picture, this would be an artery, this would be the arterioles connecting with these capillaries here. The aorta, largest artery in the body, largest diameter and thickest vessel wall. The artery wall layers are similar to that of the heart. The aorta and the pulmonary arteries, the middle layers of these vessels contain more elastic fibers than muscle fibers. They have allowed the vessels to stretch slightly as they receive high pressure blood from the ventricles. This picture here is showing you just the arteries running through a cat patient and where they all go, which is pretty much everywhere. The capillaries. Arterioles branch into microscopic vessels called capillaries. So capillaries are microscopic. They're found in groups. So the capillaries are usually found in groups, and they're called capillary beds. And this is an exchange of gas and nutrients happen here. So when we're giving oxygen to tissue and taking CO2, it happens at the capillary level. Not one cell in the animal's body is far away from a capillary bed, and that's how every single cell in the body gets oxygen from the vessels, is thanks to these capillary beds. They provide O2 and nutrients and take waste products away. In order to get blood back to the heart, the capillaries join together to form tiny little veins called venules. Interesting fact, white blood cells leave circulation at this point to enter tissues at the site of inflammation. So if we have inflammation or infection, at the venule part is where the white blood cells are going to leave the circulation. And venules join together to form a vein. And veins carry blood to the heart. Venous blood is under low pressure, lower pressure than arterial pressure, because arterial pressure, we have the heart that's helping it pump and force that blood out into the arteries, but the venous blood is under lower pressure. The veins have much thinner walls than arteries, and there's actually valves in the vein that ensure that the blood only travels one way to the heart. So when blood tries to flow backwards, the valves close. It's kind of similar to those valves in the heart that open and close, allowing the circulation in the heart to only go one way. The veins have similar valves within their vessels to help the blood just flow towards back up to the heart. And this here is a picture showing you all the veins within the cat. So again, wherever an artery goes, a vein's not going to be too far behind to pick up its deoxygenated blood. Now, fetal blood circulation is quite different, and there's major differences that happen. The fetus receives oxygen through its mother's circulation. The fetus itself does not give its the fetus's tissues don't get oxygen from the fetus; they get it from their mother. The lungs in the fetus are not needed for respiration. Therefore, there's bypasses in the fetus's heart that allow most of the blood to go around the lungs instead of going through them, because the lungs in the fetus, it's not in use. We don't care. The blood doesn't need to go there, so it doesn't. So the fetus receives oxygen through the placenta. So oxygenated blood from the mother flows through her placenta. Oh my gosh, I'm so sorry, guys. Oxygenated blood from the mother flows through her placenta into the fetus via the umbilical vein. Now, it's called a vein because it's going towards the fetus's heart. So even though it has oxygenated blood, it is called the umbilical vein, because at that point that vessel is going towards the fetus's heart. So that oxygenated blood flows from the placenta through the umbilical vein, like we said. Blood from the umbilical vein flows through the fetal liver and up to the caudal vena cava. It will then mix with deoxygenated blood from the fetal systemic circulation. Blood from the caudal vena cava enters the right atrium. So that's no different than our circulation. Most of the blood from the right atrium flows directly into the left atrium through the first bypass. Now, typically in our heart, it's separated by the atrial septum, the interatrial septum. Now, these fetuses do not have that septum, and they have a bypass there. And that first bypass is called the foramen ovale, because it has already been, the blood's already been oxygenated by its mother, right? So it doesn't need to go through the whole circulation and make its way to the lungs, which are completely not functional in this fetus. So it will just completely bypass that and go, and where the interatrial septum is, there's an opening called the foramen ovale, and the foramen ovale is between the right and left atria, where the septum usually typically would be. This picture here will show you that this is the typically where the interatrial septum would be, but there's actually an opening here. So because the blood typically would go down into the ventricle and up through the pulmonary artery to the lungs, but it doesn't need to do that in a fetus because the lungs are completely not functional, and the blood that dumped in here was oxygenated thanks to the mother. So it can actually just skip that step and go right to the left atrium to then go to the left ventricle and out. So it has a bypass here. And this picture here is calling it a patent foramen ovale. So sometimes with birth defects, once the patient's born, this shuts and closes, and then the heart starts circulating as a normal heart. But sometimes with birth defects, that can stay open, which is very dangerous. So most of the blood flows directly into the left atrium through the foramen ovale, but some of the blood flows through the tricuspid valve into the right ventricle and then to the pulmonary artery. Okay, so some blood from the pulmonary artery does flow into the lungs, or it can go through the ductus arteriosis directly into the aorta, and that's another bypass. Blood travels through the fetal aorta to the fetal systemic circulation. The deoxygenated blood from the fetus then goes back to the mother's placenta via the umbilical artery. And again, it's called an artery because it's going away from the fetus's heart. After birth and the first breath, the ductus venosus constricts, and the foramen ovale and ductus arteriosus completely close. Now, this is in healthy animals. In some birth defects, both of these bypasses may stay open, which causes major problems. So here is showing you the ductus arteriosis. So the blood will dump in here in the fetus and will go through the foramen ovale over to this atrium over here, but some will go down into the ventricle and some will push up through the pulmonary artery, but and some will go this way down towards the lungs, and nothing's going to happen, and it'll eventually make its way back. But there is an opening right here, which does not exist in anything but a fetus in normal, healthy circumstances. But there's going to be a ductus arteriosus here where blood can flow directly from the pulmonary artery into the aorta, into the systemic circulation of the fetus. And that opening, again, with the first breath, will close, typically, unless we have a birth defect called patent ductus arteriosis, where it didn't close. And there's a swap of oxygenated and deoxygenated blood going systemically, which is very bad. This is showing you the fetal circulation that we've talked about, okay? So it comes in here through the umbilical vein, and it's called a vein because it's going towards the heart. It'll go through the liver and make its way into the caudal vena cava and then dump into the right atrium. From the right atrium, some will just go right through the foramen ovale, right here, right into the left atrium. And that's fine because it's all oxygenated thanks to the mother. But some will go down into the right ventricle and up into the pulmonary artery, but it will go through the ductus arteriosus, which is showing you right here, and it'll mix with the aortic blood here. So those are two bypasses, right here the foramen ovale, and then right here the ductus arteriosus. So instead of, some will go to the lungs, but some of it will just dump right into the aorta, going to the fetal systemic circulation, and then the deoxygenated blood making its way through the umbilical artery because it's going away from the fetus's heart, and then make its way back to the mother, and then the mother's heart will oxygenate that blood again. So really, when you think about it, the mother's heart is not only oxygenating her own blood, but also oxygenating her baby's blood. So it's quite a work cardiovascularly on the mother. And valvular birth defects, we talked about this when we were talking about those two bypasses. When the foramen ovale doesn't close at birth like it should, that defect is called a patent foramen ovale. Remember, the word patent just means open. And when the ductus arteriosus doesn't close at birth, that defect is called a patent ductus arteriosus. And people often call this type of birth defect a hole in the heart. When people say, I was born with a hole in my heart, that's what they're referring to, is a patent foramen ovale or a patent ductus arteriosus, because the foramen ovale and the ductus arteriosus snaps shut and completely disappears the second that baby takes its first breath, or it should. Okay. So going back to the electricity of the heart, let's talk about ECGs, electrocardiograms, or it could be called an EKG. This monitors the cardiac conduction system. So remember, the cardiac conduction system was the electricity going through the heart from the SA node to the AV node, down the bundle of His, and up the Purkinje fibers. That's what the ECG monitors. So we have a P wave on our ECG, and it's actually the depolarization, and don't forget, depolarization means contraction of the atria. So the atria will contract and push blood down into the ventricle, and that is depicted right here on this diagram by the P wave. Then we have our QRS complex, and this wave is created by ventricular depolarization. So ventricular contraction, and that's what we see on our and that's how we see our QRS. After that, we have our T wave right here, and that is repolarization. So that's the relaxation of the ventricles. So the whole entire heart repolarizes and gets ready for another contraction. This here is an ECG showing you bradycardia and tachycardia. Sinus just refers to the SA node, so it's the point of origin. Bradycardia means a slow heartbeat, so you can see at the top, this ECG, there's quite a bit of space in between the PQRS-T waves, and that's because the heartbeat is much slower, whereas the bottom one, there's a lot less distance in between those PQRS-T waves, and that's because the heart is beating faster. Okay, so the vasculature of our patients is very important because blood collection happens from most of these veins, and one of the most common sites of venipuncture is the cephalic vein, which is the craniomedial aspect of the forelimb, and you can see that right there on the top cat picture. You can see the cephalic vein as well as in the dog in the middle. We have a femoral vein. It runs medial, the medial aspect of the hind leg. And then we have our saphenous vein, which is the lateral. So the femoral vein is on the inside of the thigh. This is typically used in cats because you can see that femoral vein. Dogs tend to have a thicker thigh muscle, so it's harder to see that femoral vein. So we'll usually go for a saphenous vein in dogs, which is on the lateral aspect, so the outside of the thigh. And then you can see a jugular vein as well on the cow. and the coccygeal vein, which is used in large animals. The cephalic vein, this is a picture of a formaldehyde cat. You can see this cephalic vein coming down here and running down into the front aspect of that arm there, and that's where we do our venipuncture. This is someone restraining this dog, and the cephalic vein runs right here, and that's where we do our venipuncture for blood collection or drug administration. This is a picture depicting the femoral vein. Okay, remember I said the femoral vein runs on the inside thigh, typically in cats, and it's number 11 here. So we will pinch off the inside thigh of a cat, and we can visualize that femoral vein and do a venipuncture there. This right here, you'll have to excuse the poor quality of this picture. This is a saphenous vein, so it runs on the lateral surface of the thigh, so the outside, okay? And you can see it there. And when we're holding off a saphenous vein in a dog, we don't typically use saphenous veins in cats, but in dogs, it's very well shown here that it runs on the outside of the thigh, and we can use that as a venipuncture site. There's also the jugular vein. It's the ventral aspect of each side of the neck in the jugular groove. So on each side of the trachea, you're going to have two veins running along there. And it is close to the carotid artery, so care must be taken to avoid accidental injection into the carotid artery. But it's fairly easy to visualize and feel jugular veins in these patients. And this right here is showing you on a formaldehyde. I do believe this is a dog, and you can see the big jugular vein running along the side of the trachea here. And this is someone holding off the jugular vein and it protruding out here. So we can use that for a venipuncture site. Jugular veins are really great when you need a large amount of blood fast. Jugular veins are your best bet.